Thank you so much for being here. Thanks for being here this morning. So just to remind you, this training has been sponsored through a HRSA grant that is given to the North Country for improving transitions of care for high-risk individuals out of the hospital into the community, utilizing care management to improve their outcomes. So we did a survey and of frontline care managers in our region, which was probably about 250 folks, and de-escalating clients and their families in crisis was a hot topic. We did a presentation, Charles O'Donnell from Albany Medical Center did a presentation on this some months ago, and the group gave some feedback in the evaluations that they would like additional training in this, and with some very practical specific examples and scenarios. So that's what we're going to be doing today. Just a couple of housekeeping things. You will be getting an evaluation, probably both in the chat and I think, is that right, Kelly? In the chat.
We're going to try.
Also, yeah, no worries. And also be sent to you via email after. Please, please, please fill that out and let us know your thoughts and also ideas for additional trainings. We'll be continuing these trainings through quarterly, probably through the end of the year. So we'd love to hear if there's another topic you want. So I'm going to let Charles give some detail about his background so you get a sense of who he is. I worked with him years ago at Albany Medical Center, and he's always done just a fabulous job of helping staff understand how to de-escalate clients in crisis versus escalating them. It was very effective at the medical center. And so I thought he would be a great person for us to learn from today. So without further ado, Kelly's going to bring up the slides and Charles will do some intro and then share his thoughts with you.
Yeah, thank you very much. And good morning, everyone. My background, which is very varied, part of it has to deal with family dynamics, which was half of my master's degree. And also I have a lot of experience working with population dynamics groups, whether they be a small family or a population of thousands. So I come at this kind of a situation de-escalating people from the individual as well as the small group and the large group, we staff folks being the large group. So we get it from all different directions with my expertise, and I really enjoy sharing this information with everybody. Okay, everyone. I've entitled this presentation, Difficult People, Intervention and Management. A tiny little bit of theory, but mostly the actual practice thing with some scenarios that we will watch. So this is going to be a review of a little bit of what we talked about in my first lecture. And hopefully this will spur some kind of discussion amongst us regarding your own clinical situations or questions that you may have. And then we can have a little bit of a dialectic and I'll learn from that. Advance the frame, please. Okay, so we're going to review emotional self-regulation and how to use this to co-regulate an upset person. The key to regulating any tense situation with any individual or group is to be able to emotionally regulate yourself. So we're going to review that and stress that. That underpins everything that we'll do in any kind of human interaction. I will also challenge you to consider designing yourself a personal script, what we will say to people in the short term that you can use as a jump off point to help get that person to a better state of mind. Okay. We're going to review the techniques to manage your own sensations and emotions, and also to always remind ourselves to frame our actions in a positive, very positive light, regardless of what's going on in our vicinity. Advance the frame, please. Okay. If you change the environment, you can change the behavior. Environment is key. There's your internal environment. There's the external environment that you have some influence on, and there's other parts of the external environment that you don't. One of the tenets of family therapy or family dynamics is this, and this applies to us dealing with our patients. And the tenet is this: if one person in a group changes their behavior, everybody has to adjust to that behavior change. If we're the ones driving our own behaviors and choosing to respond in a certain way, everybody has no choice psychologically but to adjust to that environmental change. So if we come across calm instead of reactive, they're going to more likely slide towards the calmer, more reasonable side. If we get very activated and poke the metaphorical bear, changing the environment for the negative, they will just escalate. So we manage our internal environment, we manage part of the external environment, and that's going to alter the behavior in some way, shape, or form. Advance, please. Okay. There's I call a hierarchy of danger. It's kind of an assessment thing. This has this frame here speaks to the verbal part. There's actually a verbal hierarchy of danger or activation, and then of course there's a more physical part as well. So in regards to the verbal part, if someone is angry with you and they identify you by your names, like if someone's angry at me and says, Charles, I don't think that's right, they're viewing me as a person, and we're having a person-to-person relationship. It's very difficult to injure somebody who you're viewing as a person. Another layer of this is always identify yourself by a name in any interaction, and that establishes you as a person. So if a person is angry at you and they are talking to you and identifying you by your name, they're viewing you as a person, and that's at a low level of danger. You're having some kind of communication. The next level up is when they start identifying you by a job category or some stereotype. So like in my world, it's like, nurse, I need to talk to you. So I go from being a human being to a job category, something a little bit less than a full human being. A higher level of activation may prompt that person to identify you as a body part or quality. I've seen patients or angry people call one of my colleagues Blondie, hey Blondie, and all this kind of stuff. Or I once had an angry patient's family member call me an ear because I was there to listen. So obviously I'm becoming less and less of a human being. So when someone is identifying you by a body part or a quality about you or some category they've thrown you into, ethnic or otherwise, you're becoming less and less of a human being. And the less of a human being that they view you as, the less empathy they can exhibit for you, and the less they view you as a human. The next level up is when they call you something disgusting, excrement or an animal, a pig or whatever. The disgust emotion is a very powerful trigger. And when we approach something that's disgusting, whether it's a moral disgust or physical disgust, we don't want it on us, and we need to sanitize it. And it generates a kind of a primal fear that we could get tainted by that disgusting object or person. And then the amount of emotion that other person can exhibit as they view us as disgusting can get quite high. And the most threatening level in the verbal hierarchy is when they categorize you as something evil. Some of our psychotic patients have a tendency to tell us things like, oh, you're spawn of the devil and all that kind of thing. If they view us as an evil entity or part of an evil group, then we're the farthest thing away from a human being. And as we know, evil is really, really dangerous and could harm us. So when people start calling you evil or creating a metaphor where you're like, in league with the devil or something like that, you're dealing with somebody who definitely doesn't view you as a person, and that's the highest level of verbal threat, I guess you could say, or danger. Advance the frame, please. Okay. Now there's the physical danger, starting out with that language part that I already discussed in detail. When they start getting loud, the louder they get, the more activated they are, and the less they're able to process what you're saying. So the more angry a person gets, the less able they are to think. The front part of their brain basically begins to shut down as the deep part of their brain begins to activate in a threat response. And the louder they shout, the less they're thinking. So when you come in there self-regulated at this point and you talk in a normal voice or slightly lower than a normal voice, they may actually begin to mimic this and try to match your way of presenting yourself. And I've had patients screaming at me, and within about a minute, I had them talking at a much lower volume because I was talking in a normal tone of voice. So we intervene at the lowest level possible with something to hopefully prevent them from becoming more and more escalated. Third one up on the list is when they're beginning to act out with behaviors, pacing, stomping on the floor, inflating their body position in an aggressive manner, essentially all that posturing stuff, looming over you, getting into your personal space sometimes is part of that. But they're basically acting in an aggressive manner. It's very, very primal kind of way we humans operate. The next level up, they may actually start getting violent towards objects, kicking objects, pushing chairs. I've seen people punch walls. That seems to be a very male thing in my experience. Starting to throw objects. Those of us in the hospital have probably dealt with patients flinging their dinner tray onto the floor. When you're at that level, you're dealing with a person. If they are an adult, they're operating around the psychological or emotional level of a 2-year-old, and they can kind of process only about as well as the 2-year-old. You see that tantrum behavior. When they loom into your personal space, they can be very intimidating and menacing. Of course, would make all of us feel very, very uncomfortable, and we would desire to make some space. And of course, if they're brandishing an object, I've had people throw cell phones and other telephones, or if they have some kind of weapon or anything that could be used as a weapon, anything they can grab besides, a knife or something like that. You definitely need to basically end the conversation and say, this discussion is over and go to safety. This is no time for you to start, talking to people about like, I think you need to put the chair on the floor, please. That this is time to leave, go to safety. And if you're in a situation where you can call in help and figure out what you want to do next and manage that person, then that's the time to do that. So you have to use your judgment. You have to pay attention to what's going on and where you're at. And do know people can run up and down this hierarchy fairly quickly. In the vast majority of times, you almost always have some clues or cues. Now, you may have a 15-second warning, or you may have, a 25-minute warning, depending upon how things go. So it's almost always some clues if you can pay attention to it. Not always easy to do. Very, very rarely do you have a person go from dead calm to attack mode. I've only encountered it 3 times since 1980. It can happen, but it almost never does that way. So there are always clues, and you have to have a little bit of luck to be looking at that person in a certain way to pick up on the cue, or just pay attention to the escalation and then you will keep yourself in a safer situation. And there's no shame in backing off and saying, like, obviously we're not being able to accomplish what we need for you. So I think I would like to end this conversation now. Thank you very much. Figure out your script for a tactful, respectful withdrawal if you feel the situation is becoming uncomfortably dangerous or whatever. Advance the frame, please. Okay, now a fair amount of people may not have learned the appropriate social context for aggressive behaviors, okay, or they come from a culture where aggression is part of the normal repertoire. Okay, I've worked with people who are very aggressive because in the world that they come from, they literally had to posture and get loud to be heard and get in your face. And that's the world they come from. And other people just haven't been raised to know that what you do at home, what you do in the street, and what you do when you're trying to talk to somebody who's trying to help you, they call for different behaviors in different social contexts. And often it's not the individual's fault. It's a product of the world that they grew up in order to survive. With a lot of folks, when they get aggressive, there is a subconscious assumption of danger, okay? They may have this little image in their head that all caregivers, also known as authority figures in their mind, are dangerous. And where does this come from? If persons grow up in a less than good enough environment when they're very, very little, their primary caregivers are the ones that they have a biological need to attach to approach in order to get their needs met. Because if they didn't, they would not be able to survive. They have an approach the caregiver part of their psyche, but also perhaps that caregiver when they were young was dangerous, either physically dangerous or emotionally dangerous or incredibly inconsistent. Like they're there sometimes to take care of that child, and other times they ignore them when that child is in either a physical distress or hungry or afraid. And that child will then grow up with this imprint in their mind that caregivers are dangerous, because what happens is we who visit these patients in their homes or in clinic settings, they've got in their mind that they are being dependent because they're coming in for some kind of care and we are the caregivers. And there's a map in their head that this caregiver is going to let me down or be dangerous, yet I need them. And what you might see is a lot of push-pull behavior, take care of me, but I don't want to do that. Or you may encounter them starting off with hostility because they're not sure how this is going to go, or they may misread you as dangerous, even though you're coming across as very benign. So you'll see a reaction from them that may not be consistent with what you're broadcasting. Another thing to keep in mind is we have a tendency to show that neutral face when we're dealing with people who are getting upset and escalated. And a significant proportion of people who have self-regulation problems, they will read a neutral face as threatening. They will read a neutral statement as a threatening statement. And we've all been in situations where people have seen our neutral face and gotten very angry and say stuff like, oh, you're being mad at me. And like you're standing there very neutral, or you say a benign statement and they'll flip that into something really threatening and negative, because what they're hearing and what we're saying are two different things. And it goes back to this early developmental period. So when you see these kinds of reactions, it may not be anything that you're doing that's a problem. It may be their worldview and how they're wired and how they perceive things or misperceive things that's going to cause that negative reaction at you. So keep that in mind. Okay, advance the frame, please. Okay, at base, all of us are biologically built to avoid threats. And when that doesn't work, drive the threat away. And when that doesn't work, basically destroy the threat, engage, get physical. Keep in mind that anger and rage often masks anxiety, fear, and terror. In the case of that person who is viewing us as the caregiver that they need, who also forms an image in their head of a very dangerous person, just like their caregivers when they were little, there's actually a layer of fear and anxiety in the interaction. And it's going to come out in an anger and a rage to basically drive you away. It's called drive the threat away. Often what we'll see in the hospital is avoid the threat, where they won't tell you anything. You go up to the person and you say, I can see that you're upset. Can you tell me what's going on? Are you in any pain? Is there anything you want to talk about? And then they'll come across with, no, I'm fine. I don't need anything. You can go. They may come across at that level, or in an outpatient setting, they have a huge tendency to cancel their appointments or no-show. You see that kind of behavior too. Or they're just not going to be very communicative at all, or they will basically kind of shut off and act like a statue and speak in monosyllables. Okay. Next levels up again is that drive the threat away. So they're going to be obnoxious. They're going to make sure there's space between you and them, emotional, information, and otherwise. And then you get very frustrated with them. And then the highest level is when they get really physical, and then they basically want to like harm you physically. Very, very small percent of people will actually do that, but that's the highest level of their dysregulation. They may throw stuff at you. There was a time in Albany Med, we used to say the most common weapon in Albany Med is the telephone. In the days before cell phones, people would throw the hospital telephones a lot in an attempt to, quote, destroy the threat. So you'll see this hierarchy of threat responses from people. And we do the same thing too. Somebody starts getting threatening at you, you feel threatened, and many of us, being human, will get nasty back at them because we're afraid of them. And it goes back and forth, a very primal threat response, and we wind up reinforcing each other because we're not regulating ourselves. Next frame, please. Okay. There are a lot of emotional and behavioral tactics that we use to manipulate people. We started learning how to manipulate people, I think, within the first 30 seconds of being born, and we're doing it to this very day. The issue is whether or not it's appropriate, whether or not it causes a problem. The main tactics of manipulation that you will see would be anger, guilt, and shame. And there are quite a few others that you're all familiar with. So anger, deliberate display of anger to intimidate or manipulate, and it goes right into that frame before where we're talking about the threat response thing. Okay, so, and people will use anger sometimes as a tool beyond being reactive. And because people will know that if I get angry, everybody's going to cower and get me what I want. So it's very much instrumental to get what they want. If I scream enough, they'll give me that prescription for whatever, or they'll do this for me or whatever. So anger can be a deliberate tool to manipulate, or it can be a threat response thing because they're feeling afraid. Guilt and shame are two very powerful manipulative behaviors. So we are conscientious people. It's the nature of us who've chosen to do the kind of work we do. So we really have a strong sense of responsibility, and we want to make things right. And people will play upon the fact that we will do our best to come through. So when they say things like, how come you forgot this thing you were supposed to bring for me? You said you were going to, you feel bad, even though you've told them it's out of stock, I'll bring it next time. And they will try to manipulate you by you feeling guilty because you have this high level of conscientiousness. When you can recognize that they're trying to manipulate you through guilt, then you pop that in your head, oh, this person's trying to guilt me. And then you basically de-escalate that by saying, oh, I'm sorry that this stuff is back ordered. I can't bring you the supply today. Or or you'll have to wait for this appointment. We're doing the best we can, and then leave it at that. Generally speaking, with guilt, you're not thinking about it at 3 o'clock the next morning, ruminating on, gosh, I couldn't make that appointment in the time slot that they wanted. You're not thinking about that. So guilt has its place, but it's like a lower level impact on us. Now, shame is a very, very deep driver of behaviors. And shame essentially is when somebody tries to make you feel inadequate as a person, as a human being, as a professional, or whatever. So a couple of things to keep in mind with the shame. If someone uses shame as a regular tool, you can bet that they feel an immense amount of shame themselves, and they were projecting it on you so you can carry the burden of your shame. Certain populations carry a lot of shame. I deal with a lot of folks who have like drug addiction problems that go way back in their history, and they use shame an awful lot. So they will try to make me feel very inadequate and worthless as a clinician and as a person, and say stuff like, you have no idea, and things like that, trying to make me feel shame. And I know you've all experienced individuals, patients, clients, or whatever, who have attempted to shame you. Now, we all have shame triggers, and you need to unpack yourself what really hits that shame trigger. For me, it's when people try to publicly humiliate me. It's a trigger, which draws up that shame trigger. So now that I know this, I remind myself when someone is in a group of clinicians and a patient is basically targeting me to shame me, I can say, okay, this person has a lot of shame. They're projecting it on me to A, keep themselves safe in their mind, and B, manipulate me. And then I'll do my self-regulation part that I'll talk about later, and then take the edge off of that shame reaction, and then help that person feel less shame. What you see that escalates situations when you have patients who are using a lot of shame because they have a lot of shame, and the clinician or the person interviewing them will shame them right back. And that really escalates things. What would that look like? Someone saying things like, I think you need to act like an adult, or something to that effect, can really shame people. So you have to choose your words wisely. So what you might consider is thinking, what are good replies to somebody trying to shame me that's not going to shame them back? Memorize 2 or 3 of those statements to do a limit set, and then you can counter that shaming statement with something reasonable, and then get down to the actual communication part. Now, there are many, many, many other tactics of manipulation and control. You are all versed at them. I don't have to tell you what they are because you know how to do them, like exhaling. We all do. But again, these top 3 here are the ones that we encounter a lot, and being able to work with them will give us a very good advantage of understanding that person and helping them get to a calmer, more communicative place. Okay, advance the frame, please. Okay, the key intervention is our own personal emotional self-regulation. If you're going to walk into a situation where that person has a tendency to get escalated, and you know it's going to happen again because it often does, you really need to take a minute or 2 to self-regulate. Okay, the way you self-regulate is you need to develop more acutely the awareness of how your body sensations are feeling. Literally, you're going to deal with that person who screamed at you last time, so you already know your heart rate's picking up, your palms are getting sweaty, your mouth is getting dry, your muscles are getting tense. And being able to pay attention to that is called interoceptive awareness. You really need to practice that. Now, in the modern world, over the last, I guess, 30 or 40 years of me doing this, the general population, because of the way we are raised and technology and all that, are losing that ability to pay attention to our sensations. The body runs its stress hormones, and then people get reactive. So you really need to pay attention to the sensations your body is giving you when you're about to go into a tense situation. And even after you've come out of it, you want to scan your body to get a sense of the sensations that you're having. It's the sensations tie in with your emotion. So you want to also become aware and name the emotions that are tying in with the sensations you're having that are in that situation right then and there. There's a thing called alexithymia, which basically means the loss of the ability to pay attention to our own emotions and sensations and that of others. So we have an ongoing increasing alexithymia in the general population where they can't read their own sensations and emotions very well. And if you can't read your own emotions and sensations very well, you can't read that other person. And this has been a problem that was definitely identified by the early 1990s when they first asked me to teach people how to do this with daycare children. Okay, the next frame, please. Okay, this is a very classic wheel of emotions. So after you identify the sensations you're having in your body, you want to be able to verbalize in your mind the emotions that you're having at that particular time. Generally speaking, the first thing that comes up with all of us is called surprise. You might not be startled surprise, but you will be alert, and that alertness to somebody raising their voice or a situation that catches your eye is called the orienting response. It's a biological thing. And then we pay attention. So the first thing is surprise or orient to the threat or orient to the conversation or orient to the noise or whatever. And then we'll run through usually a combination of emotions after that. When I walk into a situation and a patient screams at me, I will back up, please. I will get reactive. Fear will come up first, and then I may be angry at them. And then depending upon what they're calling me, I may actually get disgusted at them. I will not be happy and I will not be sad. But if I can identify this chain of emotions in one's head, my head, then I've got my sensations tied in with my emotions, okay, which is a very key thing. Now, I want to talk on another angle of this wheel of emotion. You see there's a pie part in the middle, surprise, fear, anger, disgust, sadness, and happiness. And then you see two concentric rings. They're kind of finer gradations of adjectives of emotions. So for example, if you dealing with a person and you can read their body language that they're having fear, and you were to ask them, and like, I see you look like you're afraid of something, can you tell me more? And maybe they'll say like, I'm scared, and you explore that question more, and then they might say, I'm really frightened that my wound care isn't going well, and I might have to get an amputation someday. And that's going to cause a prompt for a particular communication that you'll have with that individual out there in the world. But you may come into a situation, for example, where you see the same initial body language, and you'll say, I see, it looks like you're afraid, and you're going to assume it's because of their health issue. And they may say something like, I'm feeling really humiliated. Tell me more. That last person who came by to check me out, that last clinician was really, really disrespectful, and I don't trust any of you. So that's going to prompt a very different conversation. So you always want to explore using active communication, what's going on, because it's very easy to misread people and make assumptions. And the good thing about this wheel is you realize you have a lot of emotions that you can use as identifiers and to look for them. I actually give this to my patients as well. We're actually having conversations so they can pick the ones they're feeling. So it has a nice utility besides your own self-regulation utility. Okay, advance, please. All right. Biologically, if we do slow, deep breathing, what this does is it activates the part of the autonomic nervous system that slows it down, slows down your heart rate, slows down the production of stress hormones. So after you walk into a situation, you have that orienting reflex, you feel your body getting reactive, dry mouth, sweaty palms, whatever, and then you tie that in with your emotions. The next thing you will do is do the controlled deep breathing. Obviously, you can't do this when you're having a conversation with someone, but if you're going to walk into a situation, if you're doing a home visit and you got to go, in that person's house to talk with them, or you met them out in public and you're sitting there in your car, this is the time to do a minute or more of controlled breathing for you to settle your nervous system down so you can walk into that situation in a better state of mind. So essentially, you will realize that you're feeling anxious, interoceptively, name the emotions, and then you're going to inhale silently for a count of 4, exhale on a count of 6, and then repeat this. Generally, you need to do it for at least a minute. I would say if you have the luxury of doing like for 2.5 or 3 minutes, that's about the half-life of an adrenaline neurochemical in your body. So if you do your slow deep breathing for like 2 or 3 minutes, if you've got that luxury, you would have metabolized out half your adrenaline, your heart rate would have slowed down a bit, you will feel better, your brain will be thinking better, and then you will be in a better state of mind. We could do a little bit of a drill with this right now. If you visualize in your head a situation that got you, say, mild to moderately activated, you felt threatened, make that picture in your head. Pay attention to how your body was feeling at that time, okay? Name the emotions in your head that you are having at that time, okay? And now I would like you to inhale, 2, 3, 4, exhale, 2, 3, 4, 5, 6, inhale, 2, 3, 4, exhale, 2, 3, 4, 5, 6, and continue until you feel better or feel more calm. Advance, please. Okay, we always want to visualize what may happen. We as humans work off of prediction. We do it all the time. So if you have a particularly different client that you have to deal with, and you know the pattern or their pattern, you can visualize what they might do based on past history and what you might do to counter the negative behaviors to get to a particular outcome that you want to have. If you know that in the past, when you have not been able to get an item for them or make the appointment in the timely fashion that they would have wanted, and now you're going in to basically repeat this process in a new situation, you're going to know where it's likely to go, and you can predict what they might do. And if you prepare yourself with what you might want to say, what you might want to do, essentially build that script. When you walk in there, you're not going to be ambushed, and you'll already have some of the phrases built in your head already to kind of help that person work through their dysregulation. So visualization, which ties in with prediction, is something that's inborn with us. We just have to make it a tool before we walk into that situation. And you always, always, always want to have the goal in your head. So if I'm in a clinic situation and I have an angry person out in the waiting room, one of my goals is to get that person into a calmer state so we can have a communication to keep it safer for everybody and ideally get them what they need if this is possible. Oh, that was okay. Next frame, advance, please. And we actually just did this, okay? You have to recognize that you're stressed or activated. Remember that self-regulation process. Do that body scan for the sensations. Identify them, essentially have your interoceptive awareness. Identify the emotions in your head, even if it's like, I'm really anxious right now, okay? Self-regulate with the breathing. Visualize your responses, whether it be physical, verbal, it's going to be a whole behavioral thing from your perspective, and then take action. And knowing at the very bottom of any interaction that may go bad, it's basically withdraw from the situation, and then end it, go to a safe place, call for help if you need it. Okay, advance, please. All right. Be very aware of how you deliver what you say. What you say is a very small percentage of what is communicated. It's the tone of your voice, the tempo of it, the rhythm of it, how high or low, how you string your words together. All that stuff counts much more so than what you're saying. I mean, there's a big difference between saying to someone, could you please sit down? Or saying, could you please sit down? The communication is very different, even though the words are the same. Also, you need to pay attention to your body language signals. Very hard to do because we're looking out from our body, not at it. So do the best you can to manage your body's movements. And again, it's really hard to pay attention to this, but with practice, you'll get better at that. Because what your body is doing and how you're saying what you're saying are the vast majority of your therapeutic communication technique. Advance, please. Okay, so pay attention to your tone of voice. Come across as that cool, calm, and collected person. It's kind of like that late night talk show host kind of voice. Flip into your talk show host kind of voice. Very important thing. People will ventilate. Most people just want to be heard. So you're going to let them talk, unless, of course, they're bipolar and mania, in which case they'll go on and on and on. And in that case, there's a technique that we'll talk about a little bit later on. Now, some people, when they're ventilating, they get more and more angry. And you can read that body language and their tone of the voice will go up and up and up. Those people, you may need to kind of circumvent their ventilation by getting some words in the air and there to kind of talk with them. Distraction is essentially distracting them onto another topic. Distraction means the mind. So if they're really upset over how long it's taking, and then one thing I like to distract people into doing is by saying like, oh, let's talk. let's talk about what's going on here and how we can get you what you need, and focus on something positive from their perspective. I mean, literally, I say to people, well, I can see that you're upset, but you're doing really, really, really well. And let's talk about that. Reassurance is essentially straight up reassurance of, you reassure them that they're doing well. The one-on-one, obviously, if you're out in the community dealing with a patient or an individual, that's a one-on-one. Things I like to keep in mind with one-on-ones is I always put a time limit in that. I've got so many minutes to spend with you, and I put that limit expectation up at the beginning, and that way I have a way to say, okay, I've run out of time, I've got to go take care of another patient, we can pick up next time, let's make a plan for that, or whatever. If you're dealing with anybody who you feel is dangerous, you'll want to let somebody know, and so they're aware of that you're going to deal with that person. And certainly in the hospital, there are times when we'll have somebody standing outside the door to talk to that person, that patient, and break some bad news to them regarding the fact that they can't go home or such like that. So one-on-one has some nuance. Modifying the expectations basically is when they're expecting you to get ugly on them, they're getting louder and louder and louder, and they're expecting you to basically get angry and then cut off the communication, or pay attention to what they're doing, like they've thrown something on the floor. They're expecting you to say, like, why did you throw all of your dressing materials on the floor? They're expecting that. But if you focus on what's getting them upset, that's going to modify their expectation, and they're going to be actually surprised by that, and they'll be more likely to talk about what's driving their behavior. Deflecting the insult. This is a situation where you need to know what your triggers are. So if you have a particular quality, whether it's the way you look, your ethnicity, or something like that, or the way you speak, that people will pick out on and insult you with, you really need to know your triggers, be regulate yourself and have a script so you can answer them in a non-inflammatory, non-shaming method. One time I dealt with a patient. I walk into the room, the person's all activated. The person looks at me and calls me a stupid doctor. So what do I say? I don't get into a defense and saying like, I'm not a doctor. I say, sometimes people call me that, but I'm here to understand what you need. This is about you. Please tell me how you're feeling or what you need so I can help you. So again, you need to know your own triggers. You need to be not outwardly reactive. You need to have a scripted sentence, even if it's something as simple as, yeah, people call me that sometimes, or the person's called me fat, and I'll say, yeah, I could lose a few pounds, but I'm really here to understand what you need. So this is about you and what you need, and me to help you get that. So let's talk about that. Clarifying the emotional status is simply empathy. They're in a difficult situation. They couldn't get their appointment made. What can you say? When I've been in situations like that, I was angry too. It was upsetting to me as well. So you're relating to them on a human level, without saying like, yeah, you should be mad too. You want to basically show empathy. Advance, please. Okay, there are times for silence, and you know when it's appropriate. Using your nodding to show that you're paying attention. Selective focus is when you kind of pay attention to the positive parts or the useful parts of the conversation. And when they start, say, talking bad about your colleague who showed up last time, you're not going to talk about that. You're going to just focus on what the situation is in the present. Eye contact has a cultural side to it. You do want to make some intermittent eye contact with your average kind of Western person here in America, let's say. Usually it's about 60-40, 60% of the time you'll make eye contact, 40% you'll look at their shoulders. Some people are paranoid about that, so they spend more of your time looking at their shoulders. Proximity is how close you sit next to them or stay next to them. The more activated they are, the further away you get. The way I use touch in the modern world is I like to shake hands, especially when the situation is over. That handshake seems to go a long way when I'm breaking contact, ending an encounter. You have to be very careful with touch though, because people do take it the wrong way. Limitation of the audience or the stimuli. If you have a group of individuals there and you're dealing with the angry one, you may want to either bring them to a quiet area where there isn't an audience to talk with them. That's very helpful. Or if there's just too much stimuli in the area, you want to go to a quiet place. Timeout. I don't think you'll have too much of a timeout situation to deal with in your work. Body language and posture, we talked about. Be very careful of how you're standing. Okay. Now you want to build yourself some scripting. And again, with the top of it is always identify yourself by a name. So you are a human. My name is Charles and I'm here to help you. I'm here to help understand what you need. Okay. You've identified yourself as a person and you've identified the parameters of the interaction. And it's a caregiving one, knowing that some of them might be a little bit triggered. I've walked into rooms, I've talked to that patient. I said, my name is Charles. I'm here to help understand what you need. And what I got back was, you're going to leave just like everybody else does. And then I would say, no, I'm actually here for 10 minutes to sit and listen to you, and pull up a chair and listen. Okay. You're going to script yourself some phrases that you can pull up even when you're anxious. I'm sorry that makes you upset. I can hear that you're angry. I'm here to help you. I can understand why a person would feel that way, or why this might be upsetting. So choose some scripting that you can pull up immediately, and that'll be your jump off point for a question and answer or sharing of their feelings and what they want to get to some real communication. And you have to do this like ahead of time. And you probably already have things that immediately pop up in your head with certain clients that you tend to use already. So make yourself a short script for different situations, including that. Yeah, people say, people call me that before. Oh yeah, I could lose a few pounds, but this is about you. Like, that's part of my script. Okay, advance, please. Okay, limit setting process, which an organization called CPI delineates it really well. We need to back up a bit to that last frame. So oh, my frame went away.
I think, Stephanie, did we lose you or Kelly, are you showing the slides?
There we go. Okay. When you're dealing with an angry person, okay, or
Charles,
any
one
limit.
second. When you want to advance, they were having trouble here. Something's wrong with your audio. It's not you. It's not you, because I'm hearing you and everyone else I think is too.
Oh, okay. So that
So
was
just,
the lag.
I don't know, wave a hand or something so they know that you want them to advance. Will that work, Kelly and
Yes.
Stephanie? Okay.
Okay.
Sorry about that. Go ahead.
Okay. So you want to speak again in calm terms, calmly, with good attention to how your body language is. Now you're dealing with somebody who may be activated or angry, or maybe you're just doing a normal limit set for a calm person. In concrete terms, short sentences, explain what behavior is inappropriate, explain the reason why it's inappropriate. Literally don't get into a 5-paragraph discussion, just literally a sentence or two. Give them some reasonable choices that you feel are reasonable. Allow them an appropriate amount of time to make that choice, and then always enforce your limits. Situations I've used this in, I have a person who is getting very, very loud at me, and I'll say, yelling at me is please don't yell at me. Okay. You yelling at me is not going to help our communication. It's not going to help this situation with you. I would like you, and I couch these 3 and 4 in a very positive term. I would like you to make a good choice. And I'm going to give you a minute to catch your breath, and then we will return to talking about what you need. And always enforce your limits, because if you let them overrun your limits, then your credibility is no longer any good. Okay, so concrete terms, state what's inappropriate, give them a reason for why it's inappropriate. You're like in a waiting room situation, person's yelling at you. Please don't yell. It's upsetting everyone here, and it's not helpful for me to understand what you need. Give you a minute to make a good choice and compose yourself, and then we'll pick up our conversation from there. Okay, that's the way it might look. Okay, advance, please.
Charles, do you want Stephanie to show the video at this point?
It's in the next. Oh yeah, the video. Oh, sorry, it's down there. Yes, please.
Okay, I'll stop sharing screen. With the hard limit set process, you will explain what behavior is inappropriate, explain the reason such behavior is inappropriate, give the person limited and reasonable choices, allow an appropriate amount of time to make a choice, and enforce limits.
You are completely useless. I cannot stand to be in the room with you anymore. Ridiculous. You are ridiculous.
Okay, this behavior is inappropriate. It really doesn't help you get what you need. So I would like you to think about it and decide what questions you want to ask me to help you out. Or we can pick this up on our next visit.
Yeah, you're being crazy.
No. So again, your choices are to take a minute and decide what question you want to ask me now, or I will leave and we'll pick this up in our next visit.
Hey Charles, how you doing? You
Oh,
know what? I know I'm a diabetic,
Yeah.
but this is
Oh.
driving crazy all day. Can you please go and get me a dozen donuts? I just really had a craving.
Well, I know you're having a craving, but I can't get you the donuts. And you know it's going to throw your blood sugar completely through the roof. On the other hand, I can go out and get you some fruit or some sugar-free Jello or something like that. I'll give you like a couple of minutes to think about it, and you can let me know what you'd like me to get you from the better choices.
Okay. Hey, Charles, listen, I know your organization says they can't drive. You can't drive me places, but I really need to get to my sister's today. She needs my help. I really need your help in this. You have to take me there.
Well, as you very well realize, I cannot give you a ride to your sister's because it's definitely against the company rules. Besides, it's unsafe. What I can do is I can call to get you an Uber, or perhaps you can take public transportation and I can walk you down to the bus stop.
I hate the bus. I hate the bus.
Okay.
You're always talking about the bus. I hate the bus.
Well, I tell you what, I'll let you think about it for 5 minutes and you can decide between the Uber, the bus, or maybe you can call your sister among those 3 choices, and hopefully one of those will work for you. But again, I cannot give you a ride.
Okay. So you see how that operationalizes in different situations. Again, body language is really, really important, tone of voice, and helping that other person be responsible and giving them a sense of autonomy, a sense of agency among those choices will go a long way towards a better outcome. Now, will you get in situations where no matter what you say isn't going to help? Yeah, but in one of those scenarios you saw where I said, if you cannot comply with this, basically this interaction is over. Sometimes you have to do that. That's called a hard limit set. And that is sometimes necessary to do that hard limit set. So other things to keep in mind, limit setting may often elicit pushback from that person. They'll start to argue their point. And certainly if you do a hard limit set, they might get really, really angry. And then you may have to basically just back out of the situation if it's not productive at all. Your personal judgment and assessment is really, really key in that. Okay. Advance, please. Okay. So again, just like we've been saying in that yelling yelling scenario, you cannot yell at me. This is not helping me understand what you need. Please speak in a lower voice. I shall give you 5 minutes to make a good choice. I like that good choice phrasing, and decide what you want to tell me, or we'll have to end this conversation for today. And then when that 5 minutes is up, try to get back into the conversation. And if there's no compliance, you may have to end that interaction because it's only going to spin around in circles. Okay, advance, please. Okay, this is a bigger picture when you walk into a situation. Whenever you walk into a situation or you're going to go into a situation, you want to do that self-regulation piece. And again, it's what am I feeling now, the sensations, the interoceptive awareness, the emotions I'm having. You may have to do your slow, deep breathing if you need to. And then you're going to be dealing with that other individual. So you're going to be questioning in your mind, what does that person feel, need, or want? Okay. They may be able to voice that clearly with words, or maybe not. You'll have to interpret their behaviors. How is the environment affecting the person? Okay, if they're in a very noisy environment, or there are a lot of people around, or it's very, unpleasant. An unpleasant environment makes everybody feel unpleasant, even if it's their own home. So environment really makes a difference. What is the cognitive capacity of this person? How well can they understand what we're talking about? How well can they understand me? Now, we think of cognitive as, are they sliding into dementia? It can also be they're hard of hearing. It can also be the angrier they are, the less they are able to understand what we're talking about. And when they're very, very angry or very, very shut down like a statue, their cognitive capacity is very, very diminished. When they're angry, they're not going to hear you, but if you can de-escalate them through your body language and behaviors and words, and they calm down, reflecting your modeling, and their volume drops, they'll be better to able understand what you're saying. Their cognitive capacity will get closer to their baseline. You want to identify what the problem you're dealing with, because what they're saying and what they're demanding may not actually be the real problem. And you need to explore that through your active listening to find out what the real problem is, because many times what they throw at you is really not the problem. It's a little bit deeper than that. We always want to have a goal. What is it do we want to make happen with that person besides getting them in a calmer space? We may be there to accomplish an assessment. We may be there to accomplish some kind of task, addressing change, if it's that kind of thing, or some education. We need to have clear goals. What do we want to make happen with this person? And how do I best respond? That's the art of self-regulation, co-regulation, and this back and forth communication that we humans are built for. Okay, I see we have a video, a couple of videos down there.
So I was just told I can't get an appointment for drug rehab for a month. I made the appointment anyway, but this waiting is pissing me off. A month?
I understand that you're feeling frustrated and angry about not being able to get an appointment for drug rehabilitation right away. Let me try to help you with that.
Acknowledge their feelings. Start by acknowledging their feelings and let them know that you understand why they're upset.
I'm really pissed off. Finally, I'm ready to do this, and now I can't begin for another month. This is really hard. I'm scared.
I know this must be difficult for you, but please know that I'm here to help and support you. I would feel similarly if I were in your situation.
Empathize with them. Let them know that you empathize with their situation and that you're here to help.
Why is it going to take a month? What's with that?
Unfortunately, there's a current high demand for drug rehabilitation appointments, and this is causing that wait time for a month. The program is doing the best it can to accommodate as many people as possible.
Explain the situation. Explain the situation and why there is a wait for appointments. Be honest and transparent about the reasons for the delay.
What am I supposed to do in the meantime? Just wait? What if something happens?
In the meantime, there are support groups and hotlines that can provide you with the help and support you need. I can give you some information on these resources if you like.
Offer alternatives. Offer alternative resources that may help them in the meantime, such as support groups or hotlines.
I don't really know what the alternatives are. I've been dealing with this for a long time, so I think I need something sooner rather than later.
I want you to know that we will do everything we can to get you the help that you need. Your rehab appointment has been scheduled for next month, and we will be here to assist you in finding alternative resources as you wish. You and I can work on arranging those other support alternatives. Do you want to work on these today?
Reassure them. Reassure the patient that they will get the help they need and that their appointment is scheduled. There are other resources to help them, and in the meantime, if they wish to take advantage of them. By calmly acknowledging and empathizing with the patient, explaining the situation, offering alternatives, and reassuring them, you can help the client feel heard and supported, even if they cannot get an appointment right away.
Thank you. How are you doing today?
Terrible. I'm terrible, Charles.
Tell me some more, please.
I cannot go on like this. You know that things have been really difficult. They're getting worse and worse, I feel like, every time I turn around. I'm so anxious, I feel like I'm crawling out of my own skin. I can't deal with this. I need to see someone. We tried to get somebody, but we haven't followed through on that. I feel like I'm out of control. I'm losing it. I can't do this.
Okay, how long have you been feeling this way?
Oh, I don't know. It seems like years.
Okay.
But not really. I don't know.
Okay.
Several weeks. It's just
Several
getting worse
weeks.
and worse and worse.
Okay, I've got to ask this question just to be clear on this. Do you feel like you want to hurt yourself or anybody else?
No. I'm not in a crisis.
Okay,
No.
okay. So you're not in that kind of crisis, but it sounds like you're not feeling very good.
No, I'm very, very anxious. Very, very anxious. I would not hurt myself, but I'm very, very anxious. I need to see someone. I need to get some help with figuring out how to deal with the way I'm feeling. I can't do this anymore.
Okay. So what we can do is have you call the psychiatrist in the county to get an appointment. Would you be willing to do that?
You think they could see me right away? Let's try.
Well, we can try. Okay. Wait a minute, is it going? Give it another
Yeah.
tap. It is going?
Yeah.
Okay. What did they say?
All right, well, it looks like we can have an appointment in 2 months. Are they kidding? Is that a joke? 2 months? 2 months? What am I going to live like this for 2 months? I don't sleep. I can't eat. I can't do this. I can't do this. I have to see somebody like tomorrow. Today would be great. This afternoon. I can't do this. This is out of control. I can't do it. I can't do it.
I can see that you're really, really upset.
Oh yeah,
Yeah.
I'm really upset. I don't understand. You just sit and play so calm. 2 months? What were they thinking? 2 months? That's crazy.
Okay. Well, first of all, let's try and let's get into a good state of mind here. So I want you to kind of look at me, and what we're going to do is we're going to do some slow, deep breathing together.
Yeah.
It's actually going to help,
Mm.
and I'm going to count the breathing, and you go along with it. All right? Can you do that for me?
Well, I guess I can try. I have to do
Okay,
something.
give it a try. Okay. Okay. I'm going to count it. Okay. Ready? Inhale. 2, 3, 4. Exhale. 2, 3, 4, 5, 6. Inhale.
Are you
2.
sure this is going to help? Because I'm not really sure.
Wait, back to the focus. Ready?
Okay.
Inhale.
I'm sorry. Okay.
Inhale. 2, 3, 4. Exhale. 2, 3, 4, 5, 6. Inhale. 2, 3, 4. Exhale. 2, 3, 4, 5, 6. Inhale. 2, 3, 4. Exhale. 2, 3, 4, 5, 6. Okay, continue on that rhythm. How are you feeling now compared to before?
Well, it does help a little. I don't want to rip your face off.
Okay, good. That's a really good thing to do whenever you're feeling activated, upset, angry, afraid. Go into the slow, deep breathing. It will make a difference. So always,
Okay,
it's
okay.
always a tool.
Okay.
Okay, now we have the situation of 2 months for a visit. Now, did the receptionist at the office say that they were able to call you if an appointment opens up early? Yes or
Yeah,
no?
they were going to call me if the appointment opens up, but I don't know. Do they always say that and then they don't really? How can I make sure?
Well, the way to make sure is you can call them once a week, like early in the week, like Monday or Tuesday, to see if there's an opening that may have happened later on in the week. So once a week, give it a call, just inquire.
All right, that's
And
still 2 months.
It's still 2 months, but something may open earlier. So that's one thing. Another thing to do is to kind of pay attention to yourself and
Still breathing. I'm trying to.
still breathing. Okay. Now, if you're having, if you're feeling still a little bit rough this week, what you can do is call your primary care physician, and they most likely will be able to get you an appointment within 2 weeks, which seems to be the usual pattern for you. And then you'll see them within 2 weeks and see if they can help with something. And then I'm going to be back in 3 weeks, so you'll talk to the primary care physician in 2 weeks, and then me in 3 weeks, and you can look forward to that. So that's one thing you can do. Are you okay with that?
Yeah, I think that will help. But what if I get like that again in the next week or two
Okay.
before
So
my doctor's appointment?
if you are having an issue and the slow deep breathing is helping and you're feeling suicidal or completely out of control, you can always call 911 to go to the nearest hospital. You can always call that crisis care hotline and talk to them, and they can give you some guidance on what to do in regards to dealing with that. And they can also give you other advice on going to a crisis setting where you can get checked out just to make sure everything's okay, or to give you help otherwise. So there's a number of layers of things that you can do to keep yourself safe and to help yourself. And we have some of these wheels rolling already. So how do you feel about that?
It's a good start, I guess.
Okay.
We could try it.
Okay. So will you make an appointment with your primary care? Put in a call today, please.
Yeah, let's do it now while you're here, so
Okay.
I can make sure I'm.
Okay. So why don't we do that, and we'll have that down, and then we'll know when that's going to be, and then I'll be here in 3 weeks, and then you've got your backup in case you're having a crisis, and you have the skills to kind of calm yourself down with the slow, deep breathing, and we'll see how it goes.
All right.
All right, very good. Thank you.
Okay, so there are some really good examples, and you can see how there's an ebb and flow to these interactions. Person gets activated, gets angry, what have you. That happens, and you just have to kind of keep yourself well regulated, and then basically keep the lines of communication open between the two of you, and then get to some sort of situation that might bring that person to a better state. I like to teach people some skills that they can use. That slow, deep breathing scenario that we did in that second scenario, I've actually done that with quite a few patients, and the vast majority of them were open to that. Very few of them thought I was, wasting their time, but the vast majority of people would do it, and actually became part of how they self-regulated themselves when they felt anxious. Okay. Sometimes we get into situations with a parent and a pediatric patient, and then you'll have a parent who is dominating the conversation, or they may be very, very angry with you because of the situation. So you're going to have to deal with the adult first, and then help regulate them and get them to a point of being more communicative. And then, of course, you're going to have to also bring the younger person into the conversation. Some things to keep in mind with these pediatric situations is, generally speaking, all the pediatric patients, especially the adolescent ones, aren't too keen on telling you much of anything in front of their parents. So sometimes you have to actually talk to them and, away from their parents. How to engineer that is very dependent upon the circumstances, the place, and such like that. But generally speaking, you want to deal with the parent first because they are the parent, and then bring the younger person into it, and then have a conversation where the focus shifts from the parent up to the child, and then try to make the best of getting communication going with that young one. Every once in a while, when you get a multiple person situation, if it's a transcultural thing, I've had situations where I've had foreign folks from different cultures where the females don't talk, and you have a male person, whether it's a 7-year-old son or an adult, basically doing all the question answering, and it's sort of an uncomfortable cultural situation from our perspective. You may find that happening. But generally speaking, in America, we bring everybody into the conversation whenever possible to understand what's going on. And a child and a parent are part of a family, and they do influence their own internal and external environments. So we have to keep that in mind. Okay. All right. Advance the frame, please. Okay.
Charles, maybe before we get into the summary, we could just hear from folks about any of their thoughts or questions about the videos, or do they have scenarios that they've experienced and, where they really felt like they could use some, other insights about how it could be handled or so forth.
Excellent idea.
Any feedback on what you saw, or have you come across a situation that you'd like to share to see if the group can, sort of give suggestions or role play on what has worked for them or so forth.
So this is Brittany Roselle with Hudson Headwaters. Can you hear me okay?
Yes.
Great. I just wanted to make a quick comment to say I really appreciated watching the videos, and I'm really glad that they were included to see the role playing. I'm a very visual person, so seeing these techniques in action with the scenarios that you mentioned was really, really helpful for me. I can't speak for everyone, but I know I've been in these types of situations, but it was really nice to kind of really see the techniques put into action. So thanks again for that.
Very welcome. Any others? Any comments, scenarios, questions? Okay. All right. So to summarize, this isn't personal unless you make it so. So don't make the interaction personal. These folks may not know you at all. They certainly don't know your history. And they start saying things at you, to you. They don't know you. And in a sense, you don't know them very well. Don't take it personal. It only becomes personal when you make it so. So don't do that. If you can understand what drives their behaviors, the why of their behaviors, even if it's a general thing, this person can't regulate because they do lots of drugs. Obviously, they had a tragic, difficult childhood, and that's influencing their behaviors. If you can understand the why of the behaviors, you can predict the behavioral trajectory. So understand why, generally, you can predict. And if you can predict the trajectory of the behavior, you can shape the behaviors. You can't necessarily control them, but by using all of your skills, you can get them into a better place. And sometimes a better place means instead of having 10 outbursts one day, you only have 3 outbursts to deal with one day. And that is an improvement. Always self-regulate to co-regulate. It always comes from us first to help that other person, just like an adult parent regulates to help their upset child, whether that child is angry or scared. It's the same dynamic with another adult, no matter where they're at in their personal emotional development. And always be respectful, especially with limit setting. Be very careful not to come across as a shaming or scolding person that will only inflame things. And if you're in a situation where it's not working, extract yourself from it. And do know we do have some intractable people, and we just do the best we can, keeping a physical and emotional safety in mind. Okay. Any other questions at this point? Comments, stories? Yeah. Lots of references if you're interested in reading on. Okay, if there are no questions, I would like to thank you all very much for participating in today's education, and spread these techniques to everyone you work with and everyone you know, and you'll find that you'll get some good results from them. And of course, they build on your already immense skill set. Thank you very much.
Awesome. Thanks so much, guys. And if you want to share with your colleagues, this will be available on the Health Workforce Collaborative website, and your director has that information. So thank you so much, and I hope you have a great day today. Spring is coming. I see daffodils out there. I'm super excited.